Hello everyone, and welcome to today's live broadcast, Refinement of a Model of Repeated Cerebrospinal Fluid Collection in Conscious Rats, presented by Eva Maria Amen, Clinical Veterinarian, Comparative Medicine, Basel, Roche Pharma Research and Early Development, Roche Innovation Center, Basel. I'm Alexis Corrales of LabRoots, and I will be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots. LabRoots is the leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. Just click on the Ask a Question box located on the far left of your screen and type your questions into the drop-down box that appears in your screen. We'll answer as many questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, please click on the Help Desk button located in the promotional board at the bottom center of your screen, or use the Ask a Question box to let us know that you're having a problem. This presentation is educational and thus offers continuing education credits. Please click on the Accreditation button located in the promotional board at the bottom center of your screen and follow the process to obtain your credits. Please join me in welcoming Dr. Amen. I will now turn the presentation over to her.
I'm very honored to be invited for LabRoots, and I'm very happy to present our findings on repeated cerebrospinal fluid collection in conscious rats, a model that we refined here at the Roche Innovation Center in Basel, Switzerland. So first of all, I would like to give you a quick overview on the content which we're talking about today. So we're firstly going over a quick introduction on cerebrospinal fluid itself, about cerebrospinal fluid sampling in preclinical research, sorry about that, and sampling in rats here at the Roche Innovation Center in Basel. We want to look at the refinement we did for the established model we had in-house. A quick overview on the animals and methods we used, overview of the modifications we actually implemented, the outcome indicators that we looked for, finally the results and the discussion and conclusions based on those results before going over to the acknowledgements and some key references. So just for first introduction, the cerebrospinal fluid, or CSF, is produced mainly by the choroid plexus and the ependymal layer of the brain ventricular system. So you can see it right here. It is here in the choroid plexus. It then goes from the lateral ventricles over the interventricular foramina into the third ventricle, over then via the cerebral aqueduct into the fourth, and from there into the subarachnoid space. So the movement or the fluid of the CSF, it is in a single outward direction from the ventricles, but it is multidirectionally in the subarachnoid space. So it is then later drained through the intracranial and spinal arachnoid villi into the venous blood. And it does play a very important role in the homeostasis of the central nervous system. CSF sampling in preclinical research is mainly or many times used as a surrogate measure of drug concentrations, or rather of their availability in the central nervous system. And CSF penetration studies in animals still remain a practical option for the assessment of CNS drug delivery in early preclinical drug development. So analysis of CSF, or of cerebrospinal fluid, allows us to study different disease models, for instance, accumulation of extracellular beta-amyloid plaques, which are characteristic for Alzheimer's disease, or damage of the blood-brain barrier and the blood-cerebrospinal fluid barrier during multiple sclerosis, to only be able to name a few of them. So just to mention a bit of the challenge of the blood-brain barrier, we do have in preclinical research, or in total, we have the challenge of really bringing large molecules into the brain across this blood-brain barrier, because they are simply too large to pass. So the blood-brain barrier represents an obstacle in applying therapeutic antibodies into the brain, which we would need to treat neurological disorders. And up to a point that only about 0.1% of injected antibodies, which would, for instance, remove plaques in Alzheimer's disease, are really able to cross the blood-brain barrier. So we do see a limited effectiveness. However, the brain does have natural mechanisms which engage certain receptors on the blood-brain barrier, so on its surface, and these allow certain large molecules to cross it. And here at Roche, therapeutic antibodies were engineered, which were just using these natural receptors on the blood-brain barrier, and they inserted a module that binds to these natural receptors and combined them with a therapeutic antibody, and thereby enhance the uptake of the therapeutic antibodies into the brain. So we can see up to a 50-fold improvement in the uptake and in the activity in preclinical models. So this so-called brain shuttle the technology of this brain shuttle could potentially transport all types of therapeutic molecules into the brain, regardless of their intrinsic ability to cross the blood-brain barrier by themselves. So also in this regard, the study of CSF and the CSF sampling itself is very, very valuable in preclinical research. So just to give you an overview, in experimental setting, CSF sampling may be performed at either the ventricles or the cisterna magna or lumbothecal sites. So if it is in the cisterna magna, it may be with or without skin and muscle preparation at the dorsal surface of the neck. In this slide, for the ease of visualizing, we have a human skull and brain, so you can see the cisterna magna right here at the dorsal part of the neck. And in the lower picture, you can see, just for a quick overview, the location of the vertebra and of the different meninges there. Just be aware that the needle sticking in this picture is not in the subarachnoid space, but in the epidural space. So if you wanted to sample CSF at that site, you would have to insert the needle a bit further into the subarachnoid space. There are different in vivo CSF models available, both acute and chronic, and either in anesthetized or in conscious animals. In rats, there are a few acute CSF sampling models available, which can be via lumbar puncture through a skin incision. It can be via puncture of the cisterna magna. So this is what you see in the picture. You see a rat skull. So the left part of the picture is where the animal's nose would be. Then you have the skull, the cerebellum, and then you see the cisterna magna and the sampling site for the cerebrospinal fluid from the cisterna magna. There are various models in anesthetized or in awake rats available, which can be done with or without stereotaxic fixation of the animals. They normally use either repeated anesthesia and with repeated puncture of the cisterna magna, or also sometimes repeated puncture of the cisterna magna in awake animals. So we have to be aware that both repeated anesthesia as well as repeated puncturing of awake animals can be very distressful for the animals. Also, the anesthesia could really greatly bias the experimental results, always depending on your experimental readout. And we should not forget that this will be also highly, highly dependent on the researcher's skills. So there are a few challenges with repeated puncturing. mainly the manual puncture of the cisterna magna is highly dependent on researcher skill, as already said, because the researcher needs to be able to unambiguously identify the puncture site and to control the depth of the needle insertion. So you may end up with quite a few animals that are used during the learning curve until the researcher has acquired these skills. And also, we have to see that by repeated puncturing, we could end up with blood vessel or tissue damage and consequently with CSF contamination with blood. And as we now have seen the function of the blood-brain barrier, it is quite logical that this could really lead to falsification of the results, because normally the large molecule concentration in the blood is quite higher than in the CSF. So if you end up contaminating your CSF with blood, you may end up with falsified results or even with not usable results, meaning that you have been using animals and are not able to use the results created with these animals. Also, normally quite large numbers of animals will be necessary if you need to do various time point sampling, which is not very consistent with the idea of 3 hours. And also you will have the challenge of quite high inter-individual variability. However, there are also some chronic animal models for the CSF sampling available. These most often involve a surgical implementation of a cannula, which can be either in the lateral ventricles or in the cisterna magna, and in the cisterna magna it can be either through the occipital bone or through the interparietal bone. These cannulas normally allow repeated sampling of CSF in conscious and freely moving animals, because they can live quite well once the cannula has healed in and everything is closed properly. The animals can be used as their own controls, which is quite nice in longitudinal studies. So you normally are able to increase animal welfare and allow an analysis of samples without potential bias due to anesthesia. And also, one fixed cannula can reduce the risk of contaminating the CSF samples, which would most likely occur if you had to do repeated puncturing of the cisterna magna. What we did here at the Roche Innovation Center in Basel, we had an established model which had been used for quite a few years, and we had implemented some steps to refine the method. So we retrospectively reviewed it for outcome. We're talking about a chronic rat CSF model. We are talking about rats who underwent stereotactic surgery with implantation of a cannula in the cisterna magna. The cannula is stabilized onto the skull using dental cement, and after a week of recovery, the CSF can be collected in the conscious rat. And here in-house, this model has been used both for the validation and optimization of the novel blood-brain barrier transporters, so the blood-brain, the brain shuttle we have been talking about earlier, and also for the development of new drugs for the neuroscience. Our hypothesis was that by refining the method, so by implementing pathophysiological-based anesthesia and analgesia, by using state-of-the-art perioperative monitoring and supportive care, by increasing stability and adhesivity of the cement cannula assembly, and by selecting a more adapted animal strain, we would be able to improve the outcome of the model, which was quantified by perioperative mortality, by survival time, and by stability of the implant. And that thus we would also be able to greatly enhance animal welfare. The animals and methods we used, we're talking only about male adult rats. And we used the data of 40 Wistar and 339 Wistar-Han rats. Just be reminded that we're talking about a retrospective study. So the time frame in which these data were collected was between 2009 and 2014. We did stereotactic surgery with implementation of a cannula in the cisterna magna. The cannula was stabilized onto the skull using dental cement, and a series of modifications was implemented to refine the original procedure. Here in the picture, you will be able to see already the skull of the rat. So the rat is fixed in the stereotactic frame. You can see just in the front a nose cone where the animal is supplied with oxygen. You can see that the surgical field is draped. It is already prepared. You can already see that the skull has been prepared, and there are anchoring screws in the skull. The cannula is right before being lowered into the cisterna magna. Over on the next slide, you can see the rat already positioned in the stereotact. So the animal is under anesthesia. You see that the eyes have been covered with eye ointment to prevent desiccation of the cornea. The animal is provided with oxygen via the nose mask, and the surgical field has already been clipped and aseptically prepared. And in the next picture on the right side, you see that already the skull has been prepared. The animal is has been sterile draped, and you already see the skull structures for the orientation on the skull and to see where the cannula really has to be inserted. And this is a fast forward. So here you see a rat after the surgery, where you can see just on top of the head, you see the head cap and made of cement and the cannula. So this is the cement cannula assembly. You will be able to see a bit of Tygon tubing, which secures the metal mandra in the cannula. And you see that the skin is sutured around the head cap. Just to give you a quick overview of the modifications which were really implemented. So on the left-hand side, you always see the pre-refinement, and on the right side, the post-refinement methods. So in terms of anesthesia and analgesia, pre-refinement, we used a mixture of 100 milligram per kilogram ketamine and 10 milligram per kilogram xylazine, which was given by intraperitoneal injection. We did use no reversal of anesthesia. As a preemptive analgesia, 0.025 milligram per kilogram buprenorphine were given subcutaneously, and the animals also received 1 milligram per kilogram loxicam subcutaneously after surgery, which was continued per os once a day for 3 days. As opposed to that, post-refinement, animals received for anesthesia a mixture of 0.15 milligram per kilogram midatomidine, 2 milligram per kilogram midazolam, and 5 microgram per kilogram fentanyl, which was administered subcutaneously instead of intraperitoneally. The anesthesia was reversed with also a mix of buprenorphine, 0.05 milligram per kilogram, atipamezole, 0.75 milligram per kilogram, and flumazenil, 0.2 milligram per kilogram, also administered subcutaneously. As analgesia, the animals received first the buprenorphine, which was already in the antagonization mix, and also the 1 milligram per kilogram meloxicam, which had been also administered subcutaneously after surgery and continued per os once a day for 3 days. In terms of perioperative monitoring and care, pre-refinement, the animals were spontaneously breathing room air and were monitored via rectal temperature and anesthetic depth by pinch reflex. We changed that into spontaneous breathing oxygen via the nose mask. And animals were monitored with heart rate, oxygen saturation of blood, and also the body temperature and anesthetic depth by toe pinch, heart rate, and viscous movements. Regarding the aseptic technique, pre-refinement, we did use surgical gloves but we did not use sterile draping, which was then added in the post-refinement procedure. And to just let you know the dental cement, what we changed. Pre-refinement, we had a two-component cement, Paladur, which was mainly an issue in terms of occupational health and safety, because it is based on methacrylate copolymers, which emit acrid fumes and which can be quite toxic for the personnel. So we changed that. We also did a series with a glass ionomer cement called GC Fujisem. And in the post-refinement setting, we had a dual cure self-adhesive universal resin cement, GSEM, combined with a 40% phosphoric acid etching gel and light curing bonding agent. We looked for several outcome indicators. So mainly we had perioperative mortality and death. Perioperative mortality, which was defined as death under anesthesia and within 24 hours after surgery. We looked for animal survival time, defined as days of the use of animals, and rats with a survival time between day 1 up to day 60 post-surgery were considered for the statistical analysis. We looked for stability of the cannula cement assembly, which was defined by days of firm adhesion of the assembly to the animal's skull. So whenever we saw visible instability, which was noticed when manipulating the animals for checking for CSF flow, but also complete loss of the assembly, were both defined as loss of assembly. And last but not least, we also analyzed for duration of surgery, measured in time in minutes between the incision of the skin and the finished suture. And to analyze these indicators, both parametric and non-parametric tests were used. So let's get over to the results. So first of all, we have the perioperative mortality. Just to remind, it was defined as the perioperative mortality, the death under anesthesia and within 24 hours after surgery. And here we can clearly see a significant drop. So in the pre-refinement setting, we had 7 animals out of 73 who died in these 24 hours, compared to 4 out of 322. You will see that in the first setting, we have quite a few Wistar rats and some Wistar hand rats, whereas in the post-refinement, we have only Wistar hand rats. I will come to that difference in the strain later. Next result, survival time, which was, just to remind, it was defined as the day of use of animal with a cutoff of 60 days. So animals of between day 1 and day 60 post-surgery were considered. And also here, the survival time significantly increased with the refinement of the technique. So after refinement, we had 36 plus minus 14 days compared to 28 plus minus 18 days. In regards of the stability of the cement cannula assembly, also measured in days of firm adhesion, we could see a significantly higher stability of the cement cannula assembly, both compared, so of the new cement, of the GSM, both compared to Paladur and to the glass ionomer, the Fujisem. And regarding the Paladur, also both compared to Wistar and to Wistar hundreds. So there were significantly higher stability compared to all other groups for the GSM. For the surgery duration, however, we could see that the new technique was significantly longer. So this was defined as time in minutes between the first cut, the first incision, and the suture. And yes, the new cement was taking quite longer as compared to the two other cements, and we attributed that this is due to some additional intermediate steps, like several times light curing for the new cement. We have some more results, so just to let you know about the strain influence. As said, we are talking about retrospective analysis of data, and we are including data from both Wistar and Wistar hen male rats. And the reason for the change of the strain was initially the model was started with Wistar rats, but the Wistar rats have a rather steep increase in the body weight, which renders them quite large to be safely handled. And to overcome this problem, we selected Wistar hen rats, which can gain weight at a much slower pace than the Wistar rats. And we checked for differences between the strains for all the indicators we checked. So for the perioperative mortality, for the animal survival time, for stability of the cannula cement assembly, for duration of surgery, and for intraoperative positivity. And as we did not see any significant difference between these two strains for any of the indicators, we decided to include the data from both strains to also be able to increase the statistical value. We had some other considerations. So just to let you know, pre-refinement, no special attention was given to postoperative feeding. So the animals were provided with a normal standard rat jaw or rat pellets, and that's it. But after careful observation of the animals, the rats seem to have some problems with gnawing and with biting the standard rat jaw. So we presume that they were experiencing some discomfort at the surgical site when applying pressure to their teeth. So after reviewing the technique, we also offered them soft jaw after the surgery in addition to the standard pellet, so that they could really choose between the normal pellets and the soft jaw for up to 3 days. This soft jaw was readily accepted by the animals. However, we did not see any significant difference in the body weight after 1 week after surgery. So it may be that 1 week is too late to really see a difference, that we would have had to check them 1 or 2 days after surgery, or maybe the weight development in this first week after surgery. So we do not have a significant difference here, but nevertheless, at least by the animal caretakers, this was still considered a refinement by the animals caretakers, which were daily observing the animals. But just it's a caveat, this may be purely subjective. Also, another point which we changed for the refined procedure is that for the postoperative recovery phase, we always provided the animals with warmth, but first it was a heating lamp which has a more focused and more punctual warmth, and we changed that to forced air patient warming. So for instance, the bear hugger, which are the big blankets with warm air. And we seem to have observed that the animals recovered a bit better and quicker in this newer setting with the warming blankets. But again, we do not have any data on this, so this may be purely subjective. So to come to the discussion and conclusions, after the retrospective review, the in-house performance of our model was considered quite low, and the processes were analyzed and consequently refined to obtain a better outcome. And we could find that the holistic pathophysiological-driven and model-tailored refinement of the methodical part improved the outcome of the model and animal welfare by significantly reducing mortality, increasing survival time, and improving the stability of the cement and cannula assembly. What we did see was The anesthesia was tailored to pathophysiological modifications in cerebral autoregulation, which is inherent to the model, and to avoid further functional impairment. A multi-model mechanism-based balance analgesia targeting all processes of nociception, so transduction, transmission, modulation, and perception was implemented. We used state-of-the-art perioperative care, including aseptic techniques, to reduce also microbial contamination to the lowest possible practical level, and thereby reducing morbidity and mortality and increasing reproducibility of the model. And also we used a new cement type, which was not only superior in terms of occupational health and safety, by avoiding the exposure of personnel to the acrid fumes, which might be toxic, but also in terms of ease of handling, adhesivity, and the significantly higher stability of the cement cannula assembly. So in the end, we consider that overall the concept of the 3 R's by Russell and Birch were successfully addressed, and animal welfare was improved by reducing the total number of animals needed thanks to lower mortality or euthanasia due to technical failure, and increased usage time frame of the individual rats, and by improving the scientific quality of the model. I would like to acknowledge some people. So Dr. Alessandra Bergadano, my former line manager, who really made this analysis possible and who was really helping us a lot in the interpretation of the data. Ms. Muriel Breckeisen, who together with me really implemented the refinements. Dr. Lisa Sach-Pelterson, who helped us with the statistical analysis. Ms. Larissa Kohler, who did the tedious work of gathering all and putting together all the data from the retrospective records. And Ms. Veronique Dallassen and Dr. Eduard Ulrich, who also performed some of the surgeries. So you will see, of course, this has not been just invented by us, but we were inspired by great minds that came before us. And with this, I am happy to receive any questions. And I hand over back to Alexis.
Thank you, Dr. Amen, for that informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question drop-down box located on the far left of your presentation window. Type your question into the box that appears on your screen. We'll answer as many questions as we have time for. Let's get started. How long do you need to recover after surgery before they are used in an experiment?
Thank you for that question. We do give the animals 1 week. So they are allowed to recover for 1 week before being able to be placed into any experiment. And in this week, they are closely monitored. They are checked daily for well-being. They are checked weekly for the weight development. And also 1 week after surgery, they are checked for the flow of the cerebrospinal fluid, so whether it's working or not.
Our next question is, do you use the rats in repeated experiments? If so, how many experiments may the animals be used for?
Thank you. This is quite an interesting question because this is just the beauty of this setup, because the animals are, you can use them in a longitudinal study and they can serve as their own control. So yes, you can use them in repeated experiments. In our case, it's always has to be also checked with the Swiss authorities, so the country authorities, and we do have the permission to use them for 1 experiment per week for a maximum of 6 weeks, with 1 week of recovery between each experiment. And so we can perform several samplings. Each sampling, you can calculate about 10 microliters of CSF. And if, for instance, you need to do a PK study, you can calculate about a maximum 7 to 8 samplings per day for one experiment. And then you have to give them 1 week of recovery after that.
Our next question is, do you keep the rats single-housed after the surgery? And if so, why?
Sadly, we have to keep them single-housed after the surgery. So we tried also to keep them social-housed, but we experienced that as the rats can be very playful, you have noticed, I think, that we have this little Tygon tubing on the mandra, which secures the mandra inside the cannula. So there is a quite large risk that a rat will gnaw on it, will play with it. So that will then remove the mandra that seals the cannula. And we have quite a high hydrostatic pressure of the CSF fluid, which is higher than the atmospheric pressure. So an accidental removal of the mandra will result in uncontrolled spilling of the CSF, and this will first produce a strong reduction of the CSF pressure, and then it can ultimately lead to the death of the rat. So also, if you have uncontrolled opening, this will also or can also lead to infection and contamination, which also will end up with maybe death or infection of the rat and endangering the well-being of the rat.
Okay, so we have time for one more question. Why do you think it is advisable to use a reversible anesthesia protocol?
In a reversible, thank you, sorry, I have to rephrase. In a reversible anesthesia protocol, you can really allow for a targeted anesthesia time. So you have 3 agents, and each of these agents can be counteracted. So at the end of the surgery, the animals are fully antagonized, except for the analgesia, because this is also a beauty of this protocol. You have the fentanyl on the receptors, which are then displaced by the buprenorphine, but still providing the analgesia. So the animals can recover within minutes. They typically experience a smooth and short recovery phase, and especially as compared to the ketamine silazine protocol, where the recovery time is quite long normally because it relies on redistribution and metabolism, and especially in small mammals, it's quite important to keep really the recovery phase as soon as short as possible. So because the faster the animals return to normal physiology, the less morbidity and mortality you will end up with. I hope this answers your question.
Perfect. I would like to once again thank Dr. Amen for her presentation. I would also like to thank LabRoots for making today's educational webcast possible. Before we go, I want to let that today's webcast will be available for on-demand viewing through May of 2018. You will receive an email from LabRoots letting you know when this webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's live event. That's all for now. Thank you for joining us, and we hope to see you again soon. Goodbye.
Thank you. Goodbye.